Hi, and thank you for tuning in to the Charles E. Holman Morgellons Disease Foundation's YouTube channel. I'm your host, Jeremy Murphy, and today we have a very special guest with us, psychiatrist and Lyme disease expert, Robert C. Bransfield. Dr. Robert C. Bransfield, how are you doing today, Dr. Bransfield?
Good. How are you, Jeremy?
I'm doing great.
Quite well.
Yeah, it's been hot, but it's been nice. And with the hotness, we've got the disease. The first question I want to start off with is, what is the deal with COVID-19? Should people be wearing masks? And how is the situation where you live? Where are you at?
I'm on the Jersey Shore, so I'm down here in Cape May County right now. And for the most part, people are wearing masks when they're inside, like in retail stores, grocery stores. Often there's people at the front door. They won't let you in without a mask. Outdoors, it depends on whether it's an fairly open. When it's an open, non-congested area, most people are not wearing masks. When it's a more crowded environment, you'll see more people wearing masks. I saw a couple of girls on a boardwalk with bikinis wearing a mask, but seemed quite unusual. It's something that, when you would go to international airports, you would see a lot of people from Asia that would wear masks, and that's something they've done for years, but in public. But you never saw it around here much, so now you're seeing it. It's commonly seen.
That's good. I guess the science is showing that it's going to be beneficial in preventing the spread of the disease.
Well, there is some debate, although I think generally they have some protective value. But you don't want to be overconfident that they have more protective value than they really have. And there's some debate that maybe you could get lower oxygen levels if the mask is too tight. People have passed out, and maybe you can inhale things that you exhale that you shouldn't re-inhale. That's some of the debate. And but I think the preponderance of evidence is they serve some value, but they're not magic.
Gotcha. There are exceptions where people should be able to opt out. Does COVID-19 cause psychiatric manifestations?
Yes, it does seem to. There have been some suicides associated with COVID-19 and some depression, anxiety. I've seen panic attacks emerge from it. Now, one issue is the acute phase of the illness, and then the residual phase afterwards, what you're left with. And you see some people with hypoxia injury, so that's somewhat like what we see with drowning victims or carbon monoxide poisoning. And so you can see cognitive impairments. You can also see anxiety, depression, and it may be quite a spectrum of psychiatric conditions that we're just beginning to define. And just like other infections, there can be a post-infection acute phase syndrome of psychiatric symptoms that are seen. But I have had more than one patient have these recurrent panic attacks afterwards. So that would be something to keep an eye on. Now, I've seen that with Lyme patients, and you could think, is that a reoccurrence of the Lyme, which it may have been, or was that something related to the COVID itself? I think in some cases it may be a reemergence of the Lyme that was previously in remission in some individuals.
And so the acute is short-term, basically, the symptoms?
Right. The acute, you think, now some people in the acute phase get delirium. Some get post-traumatic stress because they're isolated and there's a stimulus deprivation in ICU units. And there's a lot of that goes on, and then they get a trauma reaction from that, nightmares, and but that's more a type of a post-traumatic reaction or delirium, a result from the delirium associated with the acute phase of the illness. But then you get this immune activation stage and a lot of your psychiatric symptoms associated with infections are related to some immune provocation, be it autoimmune or inflammatory, that then results in residual psychiatric symptoms that's something we still need to define. But in some articles where they looked at it in China and England, they did see residual symptoms of a psychiatric nature.
Wow. Okay, so here's a big question. What is Morgellons disease?
Well, Morgellons disease, first of all, it's a clinical syndrome that you can see that's been described, and these people present in very similar ways. And a lot of these people describe it the same, even though they've never met anyone else who's had it. And they never, I hear from people that have never gone on the internet and found out about it. They describe it in a very similar way. In many ways, it looks a lot like Lyme disease. There's many of the symptoms of Lyme, and many of these people test positive for Lyme. And one study I did with Dr. Harvey, we found a lot of chlamydia pneumonia positive reactivity, 92%. So it looks like it's some type of infectious disease, but it may not be. It may be some other toxic reaction or possibly some immune allergic reaction, but something starts it. And it's close to Lyme, but it is different. And then you have more of the skin symptoms that you don't see with Lyme. You do see some skin symptoms of Lyme, but not the kind that we see with Morgellons. You also see a lot of neuropathy. You see formication. Formication is a type of neuropathy that you can see with crawling sensation under the skin. And then people often get frustrated when they describe it to doctors, and then they say, well, this is delusional. And now there are a few people that do become delusional late in the illness. Just like Lyme disease, there's some people that become paranoid. But you don't see that early in the illness. And the sensation of crawling, the formication, is a very common sensation with many. You see it with diabetic neuropathy. You see it with drug overdoses, drug withdrawal syndrome. Certain dental chemicals can do it. And a doctor can't be too quick to dismiss it. You can also see biting, stinging, a feeling something's pushing through the skin. And that goes with the findings that you find with Dr. Middleveen and Dr. Stricker when they examine and they find keratin and under the skin. It's like some product is coming through the skin. In some ways, a little bit like uremia that you see with kidney failure, where you have urea crystals that come through the skin.
Right.
And so it's some bodily product made by the body coming through. It's not actual microbes or parasites coming through, but it's something that is a metabolic reaction from this illness that comes through the skin. And what it's not delusional parasitosis. Now, there are people that have delusional parasitosis. Invariably, they have a lot of delusions, not just skin. It's rare for someone to have a sole isolated delusion to just one thing and nothing else. And then a lot of people may go to dermatologists and they may say, well, this is delusional parasitosis, so we'll give you Pindolol. Now, Pindolol is actually a psychiatric med that we never use. And what it was originally approved for Tourette's, but it's a major tranquilizer with some adverse heart side effects, QTC reaction, which has been in the news recently with the COVID-19 treatments. But this truly has more of a risk. It's not that really minimal risk that you see with hydroxychloroquine or Zithromax. And but one thing they found was that Pindolol blocks the replication of chlamydia. And chlamydia we found being associated with Morgellons. And Haldol also seemed to block the replication of chlamydia. So in many ways, it is considered a psych med, but it has an antibiotic effect. So it may be therapeutic as an antibiotic when it's used, in reducing the chlamydia or working as an antibiotic that's at maybe the core of what probably this complex interactive infection. Now, since many Morgellons patients improve from antibiotic treatment, that makes me think that there's an infectious component to it rather than a toxic component. But I think there are variations that what we see with different Morgellons patients. So there's a bit of a spectrum. They're not all the same, and there may be different subcategories that time will tell.
That developing dementia later in life, that sounds pretty serious. Is that, or is there a most concerning aspect of Morgellons in your experience?
Well, the greater concern is suicide. There's quite
Yeah.
a bit of suicide with Morgellons. And I think when you look at that, when people have Morgellons, they often become very reclusive. They are frustrated in trying to access care. They are baffled by the condition themselves. Their family's baffled. Their doctor's baffled, and people mislabel it. And they get tired of being called delusional. And then they isolate themselves. They feel frustrated. But another part of it is they're afraid, could this be contagious? Could I spread this to other people?
Yeah.
And then they isolate themselves from their friends, family, for fear of spreading it to other people. And they get tired of explaining themselves to everyone who has trouble believing it when they have trouble believing it also. So that isolation and then the depression that goes with it and all the other symptoms can give someone a sense of hopelessness, futility, and all the distress from the different symptoms that puts these people at risk for suicide.
Well, and those are what you would call potentially red flag behaviors, that this person is in trouble and at risk for suicide. Is
right.
Now,
the other thing, a part about it is, I'm talking there about psychological risk factors, but there's also physiological risk factors. When you're in a constant pro-inflammatory state,
Yep.
It has an effect on quinolinic acid and NMDA receptors. So it actually pushes people physiologically more towards the risk of suicide.
Oh.
So there's, and that's true with any infection, any inflammatory condition increases the risk of suicidality. Particularly the more inflammation and the longer the period of time. And there are a lot of studies with that. Some are out of Denmark, where they have 8 million people in a statistical database, showing that when you have a bad infection, there's an increased risk of suicide. And we see that with many infections.
So the behavior is really just a symptom of the underlying condition.
Right. The behavior and the mental state can be a consequence of impairment to the brain as a result of this probable infection causing an aberrant immune activity, which in turn causes changes in mental functioning.
Wow. Dr. Bransfield, why is it hard for many people to accept that infections can result in concerning behavior?
Well, people forget about syphilis, and syphilis, our state hospitals used to be filled with people with syphilis, and they had the infection, and then they ended up with a variety of mental impairments from syphilis. And then once penicillin came out, there was a thinking, well, no, that no longer occurs, that infections no longer cause mental illness. And so people forgot that lesson. The other part of it is, I think your average doctor has inadequate training in psychiatry. Your average doctor, and look at a lot of times your thought leaders in, let's say, infectious disease. They maybe had a 1-month rotation in medical school in a state hospital 40 years ago, and that's the extent of their psychiatric knowledge. And a lot have a belief system that if you can't explain something, it's therefore psychiatric, and psychiatric illnesses just come from nowheres. But everything comes from something. Nothing comes from nothing. That if you have a psychiatric illness, there's a cause. And a way to think of it is our brain is a product of evolution. And we have these different adaptive circuits that help us to adapt, almost like a gear shift, adapting to different road conditions.
Oh. So
we adapt to different, for instance, in a dangerous environment, we're more fearful, and that's healthy. And with futility, we feel down, and that makes us retreat, withdraw, and regroup and redirect our energy. So in that way, depression is healthy. So a lot of these things that we consider mental illnesses are adaptive mechanisms going awry, and they're an extreme one way or the other. Social anxiety may be too much concern about what others may think of you. Antisocial is too little. You want to be in the middle. You want to be appropriate. But when you have an impairment that damages these circuits, you may be askew in one direction or the other, having too much fear or too little fear. So we see a dysregulation of these different circuits, like panic attacks is imminent alarm circuit that gets fired. You should panic in imminent danger, but you shouldn't feel that when there isn't imminent danger.
Right. So
something is going on in the brain that alters our normal adaptive capabilities. So we're shifted askew in the wrong direction, that in a way that doesn't match our life situation.
And that fight or flight mode actually propels the inflammatory state. Is that right?
Well, a lot of people in a pro-inflammatory state are more in like many people say, I never had all this anxiety until I had this infection. And now I just have this anxiety I can't get rid of.
Yeah.
And they may have phobias they didn't have. Interestingly, a lot of Lyme patients end up with spider phobias they didn't have before. I've seen it repeatedly.
Huh.
It's just an interesting observation, but you see more fearfulness that wasn't there before. But it's almost like a shotgun blast, that everybody has a different injury from a shotgun blast, and no two people are exactly the same, and that's what you see with these infections.
Oh. Because these are multi-systemic, and so they attack.
Right.
They can potentially attack everything.
Different people have different susceptibilities, so they manifest differently in different individuals. No two people show exactly the same symptoms.
That makes sense. Well, how can someone tell, though, if they are suffering psychological issues because of infection or other reasons, valid reasons like emotional trauma?
Well, they do run together, because if you have these infections, you're more susceptible to post-traumatic stress syndrome.
Oh.
In part, you're traumatized because you're not getting the help you need from the healthcare system,
right,
or from your family, and people don't understand it. That's part of it. But the other part of it is you get more in the way of intrusive symptoms. It's related to inflammation in the temporal lobe. And when you have inflammation in the temporal lobe, you can have these intrusive symptoms, and that's a core part of post-traumatic stress disorder. And intrusiveness results in avoidance, hyperarousal, and/or emotional numbing.
Huh.
So now, some illness, think of it as early developmental trauma. That's one cause for a lot of significant psychiatric illness. And trauma is where you get blindsided and something happened that you were never prepared for, and then your brain keeps going back to it, trying to make sense out of it. So that's an intrusive symptom.
Oh.
So it's but if a healthy brain that works properly would adapt to different situations, but when you have injury to those adaptive circuits, then your mental flexibility to adapt to this is impaired, and you would get stress and trauma from things that wouldn't otherwise be traumatic to someone else. So if we look at what causes mental illness, it used to be demon possession. We used to blame your mother. Then we used to, now it's, the more we look at it, infections and immune reactions and other things that trigger immune reactions, and then how they alter brain functioning. That seems to be a major thing. Also head injuries, trauma, injury from things other than infections, but that seems to be the major cause as we progress with time and understanding the etiology of mental illnesses.
Wow, the demons are actually really just infections that can be treated a lot more humanely than drilling holes in people's heads.
Yeah, or burning someone at the stake.
Oh, thank God. So can specific conditions like bipolar disorder be caused by infections as well? And what other reasons would someone suffer from BPD, bipolar disorder?
Well, bipolar disorder does seem, there's a lot of evidence linking it to infection, not Lyme disease, but other infections. So one infection we link it to a lot is toxoplasmosis.
Huh.
It's also been linked to certain chlamydia infections. And Dr. Fellerhoff in Germany looked at that and found that a number of different chlamydia species, particularly one bird-borne chlamydia ptakia, as it was called. And then another link is with human endogenous retroviruses. And these are retroviruses that get incorporated into our DNA. So they're junk within our DNA that get activated, kind of like a terrorist cell that sits in your DNA. So it is a sort of infection, but it's looking at it from a different angle. It's not so much acquired, but it's acquired genetically that may or may not then get activated.
Oh, wow.
So there are other infections. Now, for really bipolar, Lyme doesn't come up. You do see, when you do see it, it's rapid cycling, particularly when it's acquired very young. And we do see some of those cases. But I guess the vast bulk of bipolar may be associated more with other infectious diseases. And there's a genetic link, but it's a genetic susceptibility. It's not a gene like red hair, blue eyes, where there's a 50% or 25% following Mendel's laws. It's a genetic susceptibility that has partial penetrance depending on environmental triggers.
Ah.
And these triggers may be infections, toxins, deficiencies, things like that. So it's a very complicated formula. And you can see identical twins, and I've treated identical twins, and one's bipolar and one isn't. One's schizophrenic and one isn't. It's not all in the genes. And mental illness is not really caused by genes. There's genetic susceptibilities, because if it's truly caused by gene, it would be rapidly eliminated in the gene pool. It wouldn't be adaptive. And although the two conditions that go more genetically are panic disorder and attention deficit disorder. Oh, those are the two that have the strongest correlation. So those you can see more of a genetic piece to it, but a lot have to do with these environmental triggers, and infections seem to be at the top of the list. Now, when you look then at when someone goes from health to disease to health, and then you look at what happens, what you find is when you look at the genetic changes, there's certain genes that are turned on, turned off in a sequence. And those are mostly immune system genes.
Oh.
So it's the immune system is the big piece. You have infection, then you have psychoimmunology, the immune system, and then you have the manifestation. And the immune system and the neurotransmitters are two parallel communication systems within the brain.
Wow. You said, now we know that Lyme disease comes from ticks, but where does toxoplasmosis come from?
Well, toxoplasmosis is a parasite, and for instance, cat feces was one way of getting it, and it's prevalent throughout the world. There's research showing that it's higher with people that commit violence, suicide, people prone to accidents, and you do see it more and more compromised environments, but it is a quite prevalent condition. But a lot of people carry it, and it seems to be rather benign, and then other people carry it and can be quite a dangerous condition.
Huh. Wow. A lot like, well, Well, let me ask you now, you are a psychiatrist.
Correct.
And so when you suspect Lyme disease specifically, are you able to treat the patient, or do you have to refer them to an infectious disease doctor?
Well, as a psychiatrist, I'm a physician first and a specialist second, a specialist in psychiatry. So we do have fundamental training in general medicine. And when I suspected, I would do an assessment, and I've shared my assessment on journal articles I've done. And I think that's the best way to make the diagnosis. You could do blood work. There's a lot of ways of looking at confirming a diagnosis. And but then once you make the diagnosis, I may start the treatment with antibiotics to some degree, but if it gets to be very complicated, then I would refer the person to a infectious disease doctor, but particularly someone who's familiar with treating Lyme. Now, some infectious disease doctors have familiarity with it and understanding, and some don't. So I would prefer someone who truly understands it, who knows how to deal with this, instead of someone who would say, well, we just go by the surveillance criteria for diagnosis, and we go by the IDSA guidelines for treatment, and that's it. That's often the people who think that way. That's why I see so many late-stage Lyme patients with psychiatric illness. Those are all people that have been failures of our current system, that fell between the cracks. And if people were better at making this diagnosis, I wouldn't be seeing so many of these patients.
Well, but better training, you feel, could alleviate a lot of that burden.
Right. It's people who can connect the dots, so that you can see that you have an infection, you have an immune reaction that alters mental functioning and causes psychiatric symptoms. You have to see that sequence. You can't use a silo mentality and say, well, I'm just a infectious disease doctor, or I'm just a psychiatrist. You have to bridge multiple disciplines, and we're not too good at doing that in medicine. That can be super specialized. People get stuck in their own little specialty area, and you have to span specialties to really understand conditions like this.
Oh, that makes sense. So if a patient's condition you feel is infectious and they start treatment, how long does it typically take for their condition to improve? Like specifically if it's bipolar disorder, or maybe something else like attention deficit disorder?
Well, you don't exactly see attention deficit disorder. There's a difference of attention deficit disorder and attention problems you see with Lyme. But when you see the psychiatric symptoms, if it's been there a relatively short period of time, like if someone had a tick bite a week ago, that's easier to treat. Whereas the average person I saw, like in my last research project, was 9 years.
Wow.
So, but some were 40 years. Now, there were some that were recently infected, and the infection just took off, and it really progressed very rapidly. Others, it kindled and evolved, relapsing, remitting over time. So if it's been there for 10 years, you're not going to turn it around with 1 month of treatment. It's going to take more. And you look for the Herxheimer reaction, which is the worsening of symptoms followed by the improvement, usually the same symptom that you saw flare up as part of that. And if let's say antibiotics don't show improvement, then you could question. Now, the one type of, you could get a hit and run infection. It does its damage to the nervous system, and that's it, and the infection's gone. And then treating that doesn't have any benefit. But if you have an infection that's still there, that's chronic, low-grade, persistent, that can be worth treating. And you can treat current symptoms from current provocation to the immune system in the brain, but you're not going to undo prior damage that's already been done. What's done is done. So if someone's had it for 10, 20 years, you can stop it from progressing further. you may reverse some of the symptoms, but you usually can't undo everything that's been done.
So the sooner somebody gets bit by a tick that can get to a doctor, the easier they're going to be to treat.
Yes, and don't take one dose of doxycycline. Never. That's outrageous that some people do, and they still do that.
Gotcha.
So, and I think when I look at the symptoms, I say better you err on the side of over-treating than under-treatment in view of the seriousness of the long-term symptoms and the relatively good tolerability of the treatments. But it always has to be individualized. You cannot make a statement based on, you never treat a statistic. You only treat an individual patient. It's always an individualized judgment between the doctor and that patient.
That's a commendable viewpoint. What about psychotropic drugs? What are psychotropic drugs, and can they be harmful specifically to Lyme disease patients?
Well, I think any med can be harmful because a lot of Lyme patients are very drug sensitive, and it's easy to overdose someone sometimes with the smallest starting dose, whether it's a psych med or something else. So, and sometimes you go by low body temperature. Sometimes that's a giveaway, but not always. But for some reason, a lot of Lyme patients are very drug sensitive. So I often start with low doses and then gradually increase. And I think a lot of times you can always get an opposite reaction to anything. That's true with any med. But I think giving too high a dose can be a problem. But I think when you dose it properly, and a tricky thing is, because you have so many different symptoms, how do the symptoms fit together? And like, what's the linchpin? What symptom do you go after that has the most impact? Often it's improving non-restorative sleep and reducing whatever is stressing that person the most, whatever symptom is most stressful to that person. And then you work your way down the list.
Do you utilize benzodiazepines?
Sometimes, but you have to be careful. I think a lot of times when people are lost in the system and they don't know what's going on, they're giving opioids, benzos, sleep aids. They're just kind of, here, just treat the symptom and get out of here. And then they end up on a lot of high dose Klonopin or opioids, and that can go around in a circle, and then that can add a dependency or a abuse issue in addition to the original problem. And I do see a certain risk of substance use and addictive disorders when you have these chronic illnesses that aren't properly understood, addressed, and properly treated. So benzos can be useful in blocking a panic attack. I'm more comfortable with benzos with someone who's afraid of benzos, who can understand the limitations of them and understand that there's a risk. But the person who wants to just keep accelerating the dose, I have concern. I also see that sometimes, let's say, with the stimulants, and I see that sometimes with Morgellons patients, where they have this paralyzing fatigue, and then they go on increasingly higher doses of stimulants.
Yeah.
And that can make the formication worse because you get a stimulant toxicity and withdrawal that brings that out, and that's a vicious cycle. So you have to use these with discretion and know what the downside is, and not create an additional problem with dependence, tolerance, and addiction.
Well, besides the uppers and the downers, how do you feel about cannabis?
There's never really been any benefit in psychiatric illness. There's a lot of people that say, well, this helped me sleep or this relaxed me at night, but it's hard. I've seen so many negative effects. And also there's so many variations of it that you just can't predict. When somebody says cannabis, what are they talking about? Because there's so many different forms. And I've seen acute paranoia. I've seen apathy. I see explosive rage when they come down from it. I've seen cyclic vomiting syndrome. And you really the general feeling with medical societies, the Psychiatric Association, is for psychiatric indications, there really isn't any benefit, therapeutic benefit. And maybe chronic pain, cancer patients, certain seizure activity, migraine, maybe glaucoma, but that's not psychiatric. So from a psychiatric standpoint, I really think there's a lot of risk, and the benefit is very doubtful, if any.
What is the association of Lyme disease with violence?
Well, most people that get Lyme disease don't become violent, but there is a certain percent, and I did study that. I read an article about that, and you do see where it can bring out a number of different symptoms that can increase the risk of violence. And there's different ways. You see three basic kinds of violence. One kind is impulse control disorder, and that's the most common kind. The other can be delusional based violence, and the third is predatory. So impulse control disorder is what we see Saturday night in the emergency room, that people were out partying, and then they were drinking, and then around 2 a.m. When they're coming down from the alcohol, one thing led to another. But it isn't just in that setting. It's where someone gets provoked and there's counter provocation, and then things get out of hand. That's the most common pattern. And in those cases, the person doesn't have the normal restraint that they should have. Their capacity for restraint is damaged. And that's you do see that. It can be with low frustration tolerance, irritability, and there's a lot of different subcategories in there. Then the next could be predatory, that's what where someone stalks, and there's a lack of empathy, and that's a very dangerous kind. And I've seen that with Lyme, where it has a certain damage in the temporal lobe, where there's a lack of empathy in these people. And then the other can be delusional, and that I've seen. I was dealing with that. Actually, I was dealing with a couple of these cases this past week. And that's where someone has a delusion, and then they feel they have to protect themselves, and then they lose control.
Is the violent behavior reversible if it's Lyme disease?
I've seen it be reversible, and there's a lot of cases that I've seen turn around. Also, sometimes there's intrusive symptoms that contribute to it, where people get these intrusive symptoms of violence, where they want to kill every living thing in the house that just come. And so I've seen it treated, although some cases I end up seeing after the fact when the damage has been done.
Oh.
And but I've seen a lot that can be treated. And I think when you understand this, when you aggressively treat these infections, I think you can prevent a lot of violence that otherwise would have just happened. And we can prevent a lot of violence by this insight. That's the big thing. It's good news that we can do something to prevent this.
Yeah. Is syphilis still a prevalent infection, or do you feel that Lyme has overtaken it in incidence?
Well, in certain parts of the world, it still occurs and pops up. It's been quite a while since I've seen a case of syphilis. And it's in many ways, syphilis is a lot easier to treat than Lyme. And syphilis is 22 genes, Lyme is 132 genes. Oh. So it's Lyme is a much more formidable opponent than syphilis. And but both can take many forms, and they can both mental, physical, and they're called the great imitator, the second great imitator. Maybe COVID will end up being a third great imitator.
Oh, no.
I hope not, but it could end up that way.
Right.
It may take years to see that. So In the United States, I don't see that much syphilis, although there are reports. But I think there are parts in the world where you do see it.
Gotcha. So Lyme disease is probably the bigger problem here in the U.S.
Yes.
Is it harder for Lyme disease patients, and you may have said this earlier, is it harder for Lyme patients in particular to cope with emotional distress?
Well, often your average person who gets it, they were usually an outdoors active person. That's why they got it in the first place. So then they suddenly have a disease that is, and fatigue is often the number one symptom that people complain about the most. And they have all these symptoms that impair and prevent them from being what they used to be, how they define themselves. So they don't have, they have more things bothering them, and they have less coping capability. And that's a bad combination.
Wow.
So it's, and it's hard for them to understand it, and hard for the people around them to understand it.
Yeah.
So it's a very bad combination.
So their coping mechanisms only have so much before, that everything starts to overtake them, the distress.
Well, for instance, they may have sensory overload. So they can't filter out, and that's different than attention deficit disorder. So sensory overload is, let's say you go to Times Square, you can focus on who you're talking to or what you want to pay attention to. Whereas if you had this problem, a lot of people with Lyme disease can't deal with that environment. They can't filter out all that sensory input.
Oh.
That's a overactive thalamus. We can show that with brain imaging. There's an inability to filter the stimulation. Now, that's different than attention deficit disorder. Attention deficit disorder is more distractibility, although Lyme patients have distractibility also. But the sensory overload is something you see with Lyme, and then they get flooded. So they are more easily annoyed. They can be annoyed by someone chewing next to them. And they're more easily annoyed by more things. They may be light sensitive, sound sensitive, smell sensitive, touch sensitive. And then their ability to deal with that, their anxiety, they're more prone to anxiety, they're more prone to depression, they have a lower frustration tolerance. So they're more easily annoyed. Their cognitive abilities are diminished, so it's harder for them to strategize and plan and deal with difficulties, and executive functioning doesn't work as well. So when you add all that together, it's harder to contend with stress that people used to contend with. And you can see people that used to be very high functioning individuals.
Yeah.
And now when they have this combination of deficits, it's much harder to function at the level they used to function at.
It could be aggravating for them.
It's very frustrating because they defined themselves differently in the past, and now they're not what they were. Mm-hmm. And that adds to the frustration even more. They were very high functioning before.
Yeah, well, and life isn't supposed to be over that quickly, right? I mean, if you're running around jogging 3 times a week and then you go to not being able to get out of the bed, then that can that's kind of like looking at life pass you by. Is that right?
Yeah, it's hard, particularly if you define yourself as a jogger, and that's your core of who you are. And now you've lost how you view yourself. You've lost your self-image.
Wow. Sensory overload, is that as an example would be where you go inside the mall and there's 1,000 people and there's so many people that you just can't process all the information.
Right. Or you can't zero in on what you want to pay attention to.
Gotcha.
Or a thing, if you go to an arcade, a game arcade, let's say, where there's all these games going on, and there's a chain that does it now, but like on the boardwalk, they have these arcades. It would be like that, but it would be worse because it wouldn't just be the noise, but it would be emotionally upsetting too.
The lights and the people. Gotcha. Yeah. Is it how can someone tell if they are neurotic or if that is simply their personality?
Well, if you look at it, people have different traits, and your fundamental personality and trait is what it is. So there are people that, let's say, are more apprehensive and less apprehensive, and that's just a trait somebody has. Now, yeah. But when we define illness, and it's hard to define health versus illness, and I think the best definition I can come up with mental health, you can engage in productive, fulfilling, meaningful relationships and activities, and you have the capacity to deal with adversity and the mental flexibility to adapt as life situations change.
Yeah.
So you can deal with adversity when you're at work and you have challenges, and then you can go home and relax and enjoy yourself and be able to shift back and forth as the situation changes. Now, when we look at, let's say, neurotic, that's an old word we don't use really much anymore, but it's you think of that as more apprehensive, more fearful, although being fearful can be adaptive when you're in a dangerous situation.
Yeah.
But if you're excessively fearful, then you don't pursue opportunities you should pursue. But there are some people that just have that as a trait, and then they adjust their life and they can fit in that way. Just like there's some people that are the daredevils, the Evel Knievel types, and they fit in that way. And in society, you have not everybody's the same. And it's good that we have this mix in society, because you need some daredevils and you need some people that are cautious. And they fit into society in different ways and balance each other out. So it's hard to define health or illness. And I think at different times in history, when things are more dangerous, the fearful people maybe survive better. Whereas when you have to really reach out and take initiative, that other group who has more, the risk takers survive better. So it is very hard to define what normal is, but I think that definition I gave is the best that I can come up with.
Yeah, if you're able to continue with your life and progress and accomplish all the things that you want to, if it doesn't hold you back, basically, is that right?
Right. If you can have productive life, meaningful, and get joy from living, then that's what works. That's defining health. That's mental health for you.
Gotcha. And that seems like a really good goal to try to obtain. What about can Lyme disease alter a person's personality, like very dramatically? They can become a whole other person than they used to be previously?
Well, you can see that, for instance, with the people, let's say, who go show predatory aggression, or where it may damage the capacity for empathy. Although that's not many people, and sometimes you think maybe some of those have also a herpes co-infection piece to it, because why is it only a few people get that? So maybe there's some infection mix. So if for instance, if they have that lack of empathy, Kluver-Bucy syndrome is a model for this, where you take out the amygdala, and then you can replicate that.
Huh.
It's you see that with a certain predatory aggression. You see it with some types of spectrum kind of behavior, and so it can change how you behave. Fundamental personality is fundamental personality. When I went to my class reunion, people's fundamental personalities were about the same. They don't change. And that's something you can almost see in the newborn, where there's a temperament, a trait that's within us, and we're all somewhat different that way. But then when you get these illness that impair capacity to adapt, then that goes from personality traits to cross in a pathological zone, so that it can change personality. Every now and then someone will say, well, I became more artistic after I had Lyme. But so there aren't many ways that people sometimes feel better afterwards. And although that's sometimes something to look for, does something ever make you better in some particular trait? Or does it only make you worse? And So I think, and it alters people, but they're still who they are, but they have a burden that they didn't have to deal with before.
Gotcha. Well, is there a, I guess there isn't really an easy way to distinguish between behavior and personality. Is there your personality is kind of defined by your behavior, right?
Well, your behavior is what you do, and your personality is your traits, your temperament. Are you introverted? Are you extroverted? Are you high energy, low energy? Are you a contemplator? Are you introspective? It's those traits that we can do an inventory of different traits. And how are the genetic cards shuffled? What traits do you have that define who you are? So people have these different types of traits, like the Joker, or the person who's the risk taker is the risk taker. Those are certain traits that a lot of people have. And I think you are what you are. Your brain's wired the way it is. And one thing we all have in common is that we're all different. And it's those differences that make us unique. And you have to know what your unique traits are. And that's how you have to fit in. You fit in the best way you can with the traits that you have.
Gotcha. Thank you for taking time to clarify that. How important is a support network for recovery? Can someone make it without any help on their own with Lyme disease?
It's very difficult, and it's very good to have the support network, because your average thing is you look at, and I think it's better now than it was years ago, but there was the frustration that, well, I don't understand it. My doctor doesn't understand it. The NIH doesn't understand it. The CDC doesn't understand it. IDSA doesn't understand it. Who does understand it? And so, although I think you have to be careful when you go in these support networks, that the people in the support networks are the people that are still there, that are still sick. The people that have conquered it and improved are no longer there. So any of these support groups are skewed more in a negative direction. So once you recover from whatever the network is for, be it Lyme or something else, you're not going to spend a lot of time on these chat groups and support networks. You're going to be out living your life. You don't want to think about that anymore. You want that to be behind you. It's a bad memory. You want to forget about it. But so the people that are there constantly are the people that are still struggling. And you need to keep that in mind and not see that as representative of everyone. Right. That's representative of the people that are still struggling. Now, there may be a few people that have recovered and enjoy helping the other people, even though they've recovered. But most people who have recovered and done well, they don't want to think about it anymore, and they're long since gone. So you have to not get too pessimistic from all the things you hear and some of this amateur advice of what people try. And you can get sometimes bad advice, although it can be useful for support to know that you're not alone. And look at how many support groups are for Lyme disease. Yeah. Look at, how many are there, whereas, with other conditions, there aren't that many.
Right.
But the fact that there's so many support groups, and it shows that there's such a need for it, because apparently there's such a misunderstanding and mischaracterization of what it is, that support is very critical. So it is useful that we have them, but you have to see the limitations of them. And you can't look at that as a therapy group as a replacement for a doctor.
Yeah, the groups are just indicative of the problem, the underlying problem that actually exists. And then once that's resolved, there probably won't be that many groups. Once Lyme is addressed in a responsible manner.
Right. There's no support groups for people to get broken arms.
No. Oh man, that was great. So what can Lyme patients do themselves to aid the healing process?
Well, understand realistically what they're up against, defining the problem, understanding it isn't surmountable, that there are treatment options, and there are people that do understand and have a handle on it, and it can be dealt with and managed, and it's not understandable. We may call these, like in psychiatric illnesses, may be called crazy. Crazy is what you don't understand. You call it crazy until you understand it. Once you understand it, then it's easier to kind of know what to do to deal with it, recover, and prevent yourself from getting trapped by it.
Gotcha. Are hallucinations common with Lyme disease?
I've seen it about 18% or so in the research I did on my article, where I analyzed 100 patients who were CDC positive and what were the percent of each symptom. And that's a journal article that anybody can access. And a lot of times musical hallucinations. So they're different. They're it's almost like a radio on in the next room. So it's not that like a schizophrenic patient would have. It's a recognition that it shouldn't be there. Or it may be hearing a talk radio on. And when it's music, you can't pick the station. It may be music that you don't necessarily relate to.
Oh, wow.
And that's the most common hallucination, but it can be other types of, it can be visual, it can be other auditory, it can be smell, it can be sensory.
Huh. Lyme disease patients, can they experience sexual behavior deviations?
Yes, at times. It's not something a lot of people want to talk about, but I have seen cases where it alters sexual behavior, and they're treated, and then it improves, and they can get these intrusive, bizarre fantasies that come in their head that weren't there before, just like with aggression. And when you think of it, it affects sleep, it affects appetite, it affects aggression. Why not sex? It affects everything. So you do see alterations, and we particularly see sometimes with congenital cases. And that's an area that I think needs to be researched more.
Yeah. Well,
my battery's getting low, so I'm going to move.
Yeah, I was just looking. We're actually down to the last few questions. I appreciate you making time to be here with us today. This has been an incredible interview, and we're definitely learning a lot. Does Lyme disease promote narcissism like syphilis is reported to do?
It can if it affects that part of the brain that impairs the capacity for empathy. Or it's a part of narcissism is being able to reconcile opposing emotional states in different people, so that someone who's narcissistic may recognize how they feel, but they have trouble empathizing and understanding how other people are feeling, and reconciling that. And but I think maybe some viruses might do that even more so, like herpes virus. That gets back to, and that comes up sometimes with criminal issues.
Yeah.
Because when you have impaired empathy, there's a higher risk for criminal behavior.
Right. What about TBI, traumatic brain injury? Does that factor heavily into patient prognosis?
Yeah, that's bad. For instance, one case, I've dealt with a number of criminal cases. One who had committed multiple murders. They had traumatic brain injury 4 times and Lyme. Wow. And that was a bad combination. And when you have traumatic brain injury, normally the brain gets shaken around, and the most common result of that is injury to the tips of the frontal lobe and tips of the temporal lobe. So the tips of the frontal lobe can affect particularly cognitive functioning, whereas the tips of the temporal lobe, that's where you may have sometimes that damage with the emotional processing, the amygdala with empathy. So that's a bad combination.
The question I was going to ask you earlier, I was having a hard time remember, was any problem that anybody is concerned about, they should be able to feel confident to be able to tell their doctor or psychiatrist in confidence, correct?
Correct. Well, if, let's say, you say something, there's certain things where a doctor may be bound to act on it. So if someone discloses they're going to do imminent harm to self or others, then they're bound to act on that. But that's imminent is the big thing. If it's not imminent, then it's confidential. But if you have a responsibility to protect from imminent harm, then that preempts confidentiality.
But if it's just something that they may be personally embarrassed about, they're not going to have to worry about their doctor telling everybody else about it.
Then confidentiality overrides that. Now, sometimes what occurs, we have insurance companies that can be intrusive about wanting justification for treatment. And or the other way, what might be if, let's say, they say something and then it's recorded, and they could ask not to record it, but if it is in the medical record, and then 5 years later they're in an automobile accident, and then they have a head injury, let's say, and then there's a lawsuit, they may want to get the psychiatric records.
Oh.
And then for them to proceed with that, they need to disclose that. So that's something that, that's something that occasionally can come up.
Gotcha. Yeah, thank you. Everybody is definitely concerned about privacy nowadays. Dr. Bransfield, thank you for being with us. This is our last question for you this evening.
Okay.
And what research are you currently working on?
Well, one thing I'm looking at is I think disulfiram has a lot of potential for treatment. And I've seen that help. The question is how it might be with Morgellons patients. That's a question. And then I'm looking at substance abuse addiction with these Lyme and tick-borne infections and how that plays a role in pushing people in that direction. And then looking at the impact on sexual functioning. I think that's another area that's hard to, that really is kind of another thing to look at. It's hard to know where to start with that, but it keeps coming up as questions. And that's an area that would be good to research.
Wow, sounds like you're staying busy with Lyme disease.
Yes.
Dr. Bransfield, thank you so much for being here with us on the Charles E. Holman Morgellons Disease Foundation's YouTube channel. Thank you, everybody, for tuning in. And please share this video out with your friends. Dr. Bransfield, I hope you enjoy your weekend.
Good night. Enjoy yours, too. Okay. Bye.
Thank you. All right, that's it. We're done.